Hello, and welcome to a session of Digital Slide Review and Sign Out. I'm Dr. Lewis Hassel. We're coming to you from the campus of the University of Oklahoma Health Sciences Center, our program part of the Digital Anatomic Pathology Academy. We'll hope to pluck a few grapes of sweetness and excitement as we tackle one of the challenges in pancreatic pathology. I'm referring to the endoscopic needle core biopsies. These are specimens which we're seeing increasingly in our practice as more and more endoscopists tackle the use of these very fine gauge needles to obtain a diagnosis. So why do they biopsy a pancreatic mass? When I first entered this practice, very often our surgeons would review the radiographs, the clinical story, and go right to surgery. As a result of that, oftentimes we didn't see the biopsy. We saw nice resection specimens and so forth. But there are certain non-surgical diseases that can masquerade as a mass and potential surgical candidate. And some of those patients may even need surgery, but sometimes they do not. So chronic pancreatitis, groove pancreatitis, some of those type of lesions don't necessarily require surgery. And certainly autoimmune pancreatitis can masquerade as a pancreatic mass and does not need surgery, and in fact responds very well to most steroid treatments. Sometimes, however, we need a biopsy in order to establish a treatment plan, especially if we're thinking that this patient may benefit from neoadjuvant treatment and become a surgical resection candidate. We're going to want tissue to be able to verify that we've got cancer and we know what we're treating. Sometimes they want tissue for additional studies, marker screening or trial eligibility standards or other kinds of considerations come into play. And then, of course, histology does matter, and certain histologic types may be treated quite differently than other histologic types of neoplasia. So that becomes a reason for us to do a biopsy. Now, conventionally, the needle biopsies of the pancreas were done transabdominally. And so you would often get a fairly healthy sized biopsy like this one, maybe a 18 or 16 gauge needle perhaps would be used with localization techniques radiographically to find the mass and get a nice piece of it. And in those circumstances, we often have some level of preserved architecture. Here we can see on this end acinar architecture. We can identify the individual acini, the vasculature, and so forth. And then we can see on this end, we've got our neoplasm, areas of necrosis, and so forth. So this is not difficult to identify this as a neoplasm. It is a somewhat unusual one, but we do also see here some of the criteria that become useful. So we see an infiltrative pattern of atypical single cells with a fairly high degree of nuclear atypia. We see infiltration adjacent to a reasonable sized blood vessel. Certainly we see the sclerosis and the reactive desmoplasia that often accompanies tumors in the pancreas, as well as chronic pancreatitis. Now, this is an interesting tumor in the sense that we have quite evident squamous pearl formation and keratinization in many of these little foci of tumor. So we've got a carcinoma that has squamous differentiation. What we don't see is whether or not this is associated with a conventional adenocarcinoma as well, and therefore an adenosquamous carcinoma, or whether it is in fact a metastasis from another site. So the contrast, however, between that very chunky biopsy and these very small gauge needle cores that we see with the endoscopic needle biopsies is quite striking. So these are usually 25, sometimes 26 gauge needles. So we don't get very broad swath of tumor. And in fact, we oftentimes get a lot of blood along with this, and we get fragmentation of the fragments. and fragmentation of the epithelial component. So it sometimes sort of floats off the end and so forth. So the defining features that we're trying to look for can be a little bit challenging. Here we see some sort of columnar epithelium. We see this desmoplastic stroma, but is this chronic pancreatitis? Is it an IPMN? Is it invasive cancer? Those are the questions and the differentiation that we're trying to make with this process. As we look at these individual tumor fragments, it's sometimes very difficult to ascertain, is this an infiltrative pattern here? A small group of cells here and here? It could be, or it could be the edge of one of these. Cytologically, the atypia sometimes can help us, and here we see a mild degree of cytologic atypia, some variation in size and shape. The standard that we try to shoot for is a 4-to-1 difference between largest and smallest cells, and I'm not sure we're getting there all the time here. Now we also look for a tumor diathesis. Are there incomplete glands and tumor extending or tumor diathesis? Well, here's sort of a tumor diathesis, but the fragment is fragmented, is already incomplete. We can't really tell if this is an incomplete or partial gland. So it's a little bit more difficult. We're getting some features, some suggestive changes here to suggest that this may be malignant. Here we see some normal acinar epithelium and parenchyma. And then we see here some perivascular growth. Here we're starting to see higher grade nuclear variability. Here's this large cell here, and here's smaller cells. That's more than 4-to-1. And then we see this very helpful atypical single cell infiltrative pattern going into the stroma, as well as here again, tumor diathesis inside the gland. So right in this field, we've got just about all the things we need to make a diagnosis of carcinoma. Here's an even better view here. We see this infiltrative pattern, complex glandular appearance, single cells, atypical cells. So with that kind of a find, and here's more of it over here, we can conclude that this is an adenocarcinoma. It certainly looks like it's a ductal type, and it may have some larger components that we're seeing. Now there's a finding up here that we would not necessarily jump at. Here's a little residual nest of an islet cell. And it's important to recognize that when you get chronic pancreatitis, when you get parenchymal atrophy, it's the exocrine component and not the endocrine component that's going to atrophy. And so not infrequently you can find residual islets. They're not islet cell carcinoma. They're not anything like that to be concerned about. Big chunks of necrosis, yes, that is suggestive of neoplasia, but difficult to make that into the diagnosis. Here again we see necrosis, a little bit of atypia in the stroma, so very suggestive here of adenocarcinoma. So I think with this case, we've come to the conclusion that we have adenocarcinoma as well as benign parenchyma, and it's a ductal type. Well, let's look at another example, and here we've sort of highlighted some of the areas of potential interest to begin with. As we look here, we see an inflamed background, and we see this surface epithelium here, or this nice mucinous epithelium. This is not high-grade atypia. This could be seen with Panin. It could be seen with intraductal, IPMN, or it could be seen with, intraductal neoplasia of low grade. And this stroma looks a little bit cellular and atypical, but I don't see anything I can definitely hang my hat on as invasive carcinoma. Maybe some of that, but that might take some immunostains. And sometimes those are helpful to identify these little infiltrative nests of tumor. If we do have acinar tissue, evaluating the large glandular component that's with that can sometimes be helpful. But because we don't have a larger architecture, we can't tell if this duct is central within the acinus or if it's a peripheral infiltrative adenocarcinoma. Here's a couple of atypical cells here, but you'll see that there's a little bit of similarity to these acinar structures. And so these atrophying acini can sometimes be a pitfall for carcinoma. Let's go to the next field here and look at this area here. And here I think we see maybe a few more suggestive things. We've got, again, this low-grade epithelium on the surface, a little bit of a ductal-like space, and then we've got a few angulated nests here, maybe some individual single cells and some atypia here. Not quite 4-to-1 level of atypia, but certainly becoming more suspect architecturally for possibly invasive carcinoma. And then we'll go to the last area here on this fragment. And here we see, I think, more definitive evidence of neoplasia. We see this sort of sheet-like area, a destroyed vessel, and higher degree of variability, 4-to-1 certainly met there. Irregular, incomplete gland structure here as we look at that. And then coming down here, more of this sort of change again here in this area. And finally, on the very tip down here, we can see nice, very atypical cells, irregular nuclear membranes, hyperchromatic, and irregular architecture. So this slide, this biopsy, easily diagnosed as adenocarcinoma. Now another one, maybe a little bit more difficult. As we look at this case, we see there's more acinar parenchyma. Again, we have this desmoplasia around it. Here's a large-sized vessel with, one cell here. I don't know if that's a resolving acinar epithelial cell or if that's cancer. Difficult call. Certainly, if we see a gland like this right next to a big vessel or around a nerve, we would regard that as carcinoma. But in these needle biopsies, we're not always going to find that. But looking and seeing what you can find from the architecture of where these vessels are can be very, very helpful. Again, more acinar epithelium, some small dark nests, some surface type epithelium with sort of abundant mucin, basal nuclei, so could be IPMN, could be a mucinocystic neoplasm. Don't see the stroma, of course. So again, you've got lots of blood here, and sometimes you want to look at what's in the blood, but sometimes that's not always very helpful because you may not have enough cytologic atypia there to make that diagnosis. Looking here at this fragment, again, we're seeing sort of atrophying acinar parenchyma. We're seeing here maybe a distinction between this surface epithelium and this more ductal type epithelium. You can see there's a different degree of atypia between these two areas that are closely opposed back to back. And then here's more of this type of mucinous epithelium that we associate with ductal type neoplasias that are well differentiated, IPMNs and MCNs. And then here we see this one area of an infiltrative glandular pattern. Not a glandular, but a single cell type pattern with atypia and an infiltrative pattern with a reactive stroma. In fact, that is the only atypical focus on this slide, or at least the most atypical focus. And if I don't have other factors, if I can't find other features after levels or immunohistochemical stains, I will use a factor like that to provide a somewhat hedged diagnosis, highly suspicious or suspicious for. And then when I say that, in order that I'm not misunderstood, I will oftentimes provide in a note some level of my estimation subjectively as to what the likelihood is that this represents invasive neoplasia based on the morphology, not based on the clinical history, not based on the radiographic findings, based purely on the morphology. And if I only have one really good solid criteria for malignancy, I'm probably going to be only maybe 75, 80% sure that this is carcinoma. And I think the clinician needs to understand that as they make decisions. Now, they can certainly enhance that certainty based on radiography and other findings, correlative findings, and that's fine with me. But they need to understand that there's some limitations to the amount of data we can get from these very small needle core biopsies. Well, just as in resection specimens, there are certain clues that are very helpful for diagnosing malignancy. And we're not going to always have all of these factors. So I've listed them here in sort of two categories. The very helpful or virtually diagnostic features that would say this is cancer and nothing else. So that would include perineural invasion, incomplete glands with luminal necrosis, as we saw in one of our earlier slides, very close proximity to large vessels of glandular structures. This is maybe not quite 99%, but it's certainly a very strong predictor in tissue, but maybe a little bit less certain in small core biopsies. Single cell infiltration, as we just saw, very helpful. Not quite as certain because of the variability of atrophy from acinar tissue and so forth. High-grade cytologic atypia with high-grade nuclear variability. This is a pretty strong criterion. Obviously, vascular invasion or lymphovascular space involvement. And then finally, if you should happen to be lucky and see nodal involvement, those are all virtually diagnostic. Not quite so useful, however, is that stromal desmoplastic response. We can see that in chronic pancreatitis and in other reactive phenomena. The inflammatory background, likewise, not specific for malignancy. Necrosis, fairly helpful, but not a sine qua non for carcinoma. And similarly, a haphazard growth pattern can be very helpful if you've got a large section with certain tumors like acinar carcinoma, but a little bit more difficult to define on a needle core biopsy, and so not quite as useful. So just as a little treat, another biopsy sample, small cores, a lot of blood along with these, and an awful lot of this is acinar parenchyma. We see lots of acini here, some fat, a little bit of fibrosis, and then we see some stuff that looks a little bit different. A lot of blue, but there's not much stroma to it. And sort of amphiphilic cytoplasm. Not sure if we're getting a ductal differentiation here, but it looks like this may be tumor. And so not everything is ductal carcinoma. And this is one of those situations where immunohistochemistry can be useful. Here's another fragment that looks, actually it turns out to be acinar tissue. So you can see how easily these could be mistaken, whereas this fragment right down here looks a little bit more like the tumor cells that we just looked at. So in this situation, because we're concerned that this may not be a usual ductal carcinoma, we did some immunohistochemistry. Also note here that there's a sense that this is discohesive because you see all of these cells are small tumor cells admixed with part of the blood clot. So here's our immunohistochemical stain, and we can see here that we're getting a lot of reactivity in these tumor cells, both in the tissue as well as in the blood clot. It looks like it didn't scan particularly well here, but I think you can agree with me that this is a positive stain. This is a synaptophysin stain. Now the Ki67 stain in this case was a very high labeling index, and so this is actually a high-grade neuroendocrine carcinoma, not a well-differentiated neuroendocrine carcinoma or neuroendocrine tumor. So it's a little bit of a lead around on the utility and the pitfalls and the challenges with pancreatic needle biopsies, especially as we get into more endoscopic needle biopsies. I think practicing and being aware of these criteria and being diligent in searching them out is going to be important for you. So we did see several examples of pancreatic adenocarcinoma of ductal type today, as well as the high-grade neuroendocrine carcinoma. I will post the links to these slides so you can study them on your own after the fact. We hope that you enjoyed the program and that you will subscribe. Hit that button there, and if you liked it, please make some comments and share it with your friends as well. We do plan to continue to release videos on the channel, so subscription will make sure that you don't miss those. It does help a lot. And so until next time, thanks so much for joining me. It's been a pleasure.